Okay, sir. Sir, we are live in next 30 seconds.
Just let us know when we are live after
Okay,
30
sir.
seconds.
You know, he's saying let's know when we are live.
Sir, we are live now. Good to go.
Yeah, thank you. Very good evening to all the participants, all the doctors. I welcome you all to this fourth series of masterclass. This series is As Blues, and in association with Foxy Sexual Medicine Committee, we warmly welcome you all to this fourth masterclass. We are already halfway down, and it was a wonderful journey so far. And I am sure today also it is a power pack session and lot of exciting things are waiting for you. I also welcome all the faculties and chairperson of today's session to this forum. Friends, this session will be moderated by Dr. Neeraj Jadhav, a chairperson of Sexual Medicine Committee, and Dr. Apurva, who is also looking after public relations of Sexual Medicine Committee. And as always, they are running show wonderfully well. And today also, I cannot wait much to see the session. Also, the topic is very much path breaking. Like previous three topics, it is erectile dysfunction. So without taking much time, I would like to hand over this session to Dr. Neeraj. Over to you, sir.
Sir, please unmute yourself. Neeraj, sir.
Thank you, Like. Good evening, friends. On behalf of Sexual Medicine Committee Foxy, I welcome all of you. Let's start with prayer to Almighty God to keep all of us safe in extremely difficult time of COVID. Second wave now looks like in declining mode. Cases are falling, but please take adequate precautions. Don't lower your guard. We have successfully completed 3 sessions of masterclass. We have covered all important aspects of the female sexual dysfunction in previous 3 sessions: desire disorder, orgasmic disorder, and pain and penetration disorder. We got so many good feedback for it. So now it's time to start understanding the male sexual dysfunction. So today we will cover the erectile dysfunction. Erectile dysfunction, or generally known as impotence in layman, is an inability to get and keep an erection firm enough for sex. Having erection trouble from time to time isn't necessarily a cause for concern, but if erectile dysfunction is an ongoing issue, it can create stress, it can affect the self-confidence and contribute to relationship problems. Problems getting or keeping an erection can also be a sign of the underlying health condition that needs treatment and the risk factor for heart disease. And in this COVID era, we all know there are some studies which indicate that COVID can lead to erectile dysfunction. So without wasting much time, let's start the session. For today's session, we have very dynamic personality with us, Dr. Rishikesh Pai. He is past Secretary General of Foxy and President-elect of Foxy. He has so many achievements to his name. He is a leading IVF specialist of India in a part of so many associations. So I welcome you, sir. Please bless us with your word. Over to you, Rishikesh, sir.
Thank you, Neeraj. First of all, let me congratulate you. You have been one of the most dynamic chairmen of the Foxy at present. We have 27 chairmen and your activities have been phenomenal. And, it's a path-breaking activities and really appreciate it. And I hope that you continue doing this work for the next 3 years. And along with you, Dr. Apurva Kumar Dapta has also done a great job. I would like to welcome my friend and one of the leading andrologists of the country, Dr. Sunil Jindal, who is also very good in his work. He has done a lot of path-breaking work, and I'm happy that he's there with us today. And then our two younger gentlemen, Dr. Parash Shah and Dr. Rahul Reddy, also who are doing very good work in the country. So you will have a fantastic piece of knowledge because this is one area which we as gynecologists are not aware of. But I feel that this is such a very important area. If there is a dysfunction, it can be has a lot of repercussions in the relationship between a husband and wife. And if you have got a repercussion, then your whole life can be unhappy. So it's very important contributor to the happiness of life. So I was also thinking in my mind that Neeraj, one suggestion to you and Sunil and Apurva is maybe you should do a survey, because I was thinking when before coming here that what about the COVID? Has it reduced the sexual interaction between people? How are we going to in the future? What is going to be because when HIV pandemic came in, it was a slow pandemic. So unfortunately, it's a labile virus, so we could control it. How is COVID going to influence sexual activity in society in general? What are the short term, long term? So you need to get together a survey, find out, is it that because the sexual activity will go down this year and last year, is it going to influence our population numbers? Are children going to be produced lesser? We don't know. Means there are a lot of this. I was just thinking that it's so important part of life, which which in gynecology says somehow not, though the Foxy has realized it, they have a chairmanship for it, but you have really brought it up in a very good way. And I think this is one of the greatest thing that like COVID has done, in the sense in the Zoom, the electronic media, a lot of educational activity has been done. So without much delay, I would also be interested to learn a lot from all of you. And I would like to wish you the very best. And I'm thankful and grateful for you to have called me for this function. Thank you.
Thank you, sir. Now I welcome my co-moderator and National Coordinator for Public Awareness of our Sexual Medicine Committee, Dr. Apurva Datta. Apurva, please introduce our three masters for today's sessions. Over to you, Apurva.
Thank you so much, Neeraj sir. First of all, thank you so much, Rishikesh sir, for coming and giving your precious time and for your kind words. Thank you so much. We have a very three esteemed faculties with us. They don't need any introduction. First, welcome Dr. Arasa sir. He is Chief Consultant, Sexologist and Fertility Specialist. Dr. Sunil Jindal sir. He is a Chief Consultant, Laparoscopic Surgeon, Andrologist and Reproductive Medicine Specialist. Welcome, sir. Our next very dynamic faculty with us, Dr. Rahul Reddy sir. Rahul Reddy sir is Chief Microsurgical Andrologist. Welcome all you in this session. And let's, without wasting the time, we are directly jump into our scientific session. We all know that in this era, there is a hue going on that COVID is definitely have some effect on the sexual dysfunction. And one of them is the erectile dysfunction. And that's why we purposely choose this topic so that in general, we can clear all the doubts related with that. So, sir, but Sunil sir, I welcome you. Sir, questions to you is, sir, we know everybody is heard about the erectile dysfunction from since teenage, and what we are getting from the internet, from the PAL, and there is a lot of confusion about what is actually the erectile dysfunction is. So can you just elaborate what actually is what actually is erectile dysfunction? How will we classify it? And what is the basic pathophysiology behind the erectile dysfunction? Neil sir, over to you.
Sir, you have to unmute.
Please unmute, sir.
Thank you very much, Dr. Apurva, for your kind words. And thank you very much. And I'm blessed to have Dr. Rishikesh Pai as the chief guest today. He has not only been a close friend, he's been a mentor in so many ways for me. And thank you so much for being here. How many of you want to know about male sexuality, male sexual health? If you do really want to know, let me thank you for being here in this afternoon. Though we are all at home, but we could have been doing anything else, but staying over here, listening to male sexual health would be something which would contribute to your patients. Thank you so much. I will share a small story of my life because of which I got interested in sexual medicine. I had started my practice and One day, I still remember it was 15th of August, 1998. Because I remember 1998, I started my practice. And because I had started my practice, even on a holiday, I would sit and wait for patients. And this patient entered the clinic on 15th of August. And after entering the clinic, the first thing which he said to me was, I'm going to commit suicide. Before committing suicide, I thought I'll meet you. इस बात को सुन के मेरे को बहुत हैरत, I was really engaged कि why is this man talking to me like this? In fact, I feared it. I said, if he's written a letter and he writes my name in the end, I'm going to be in a soup. So anyway, I asked him, what's the problem? And he said, I'm getting married on the 18th. My parents are forcing me and I cannot perform. And the next sentence was, I don't want to waste the life of another woman. So it was his fear inside him. So in those days, in 1998, Viagra was not available. Tadalafil and all these drugs were not available. So I remember having just told him to keep calm, took him inside and gave him an intrapenile papaverine to test. He had a good erection. And I showed, you can have a great erection, my friend. You are absolutely fine. Gave him a vitamin C, I still remember. And I told him, at the time when you're going to have intercourse, keep this tablet on your tongue. And if it is sour, it means the work is on. Can you imagine at 5 in the morning the next day, I think it was 6 in the morning, I got a call. Aapke charan kahan hai? Thank you very much. My job is done. And I realized what an amazing line this is. For somebody, it may be something to think very lightly about in humor, but for other people, this is their whole life. And for a man, it is his life. Let me be honest. A man is so much interested in being able to perform properly that I do not know. We were just discussing that most of the men don't even know where their brain is. And so this is the way it is. So I have a small presentation over here. It's so nice, Dr. Rishikesh, you are here, because I wish you could speak, because you honestly can contribute so much to so many subjects and with the humor which other people do not have. That's the beauty. So I'll just like to share my presentation now. And
presentation actually once, no, when I have done my MD, I was actually thinking of entering the field of sexual dysfunction.
really?
Because I was a bit confused. I was, I had read about Masters and Johnson. I was planning to go to USA and train there. But because my father, who was a family planner, he was the original sexual dysfunction trainer. He trained even Prakash Kothari. My dad was the director of family planning. And when during his talks to all the medical officers and all, he was from KM Hospital, Harvard educated, Padma Shri. So he used to also talk about sexual dysfunction. So he was one of the earliest pioneers of sexual medicine, sexual education, etc. So, at one point I wanted to enter this line. So I take it very seriously, this line.
Great, sir.
Sir, if it happens you entered into the sexual medicine, then it will be definitely great benefit for sexual medicine. But in the same time, it will be the loss for the IVF. No, so sir,
but what happens is that somehow in our country surgical work. So see how Sunil is there. Sunil is doing surgical as well as sexual, but sexual medicine is also a very, in fact, I rate it higher than even infertility line, because infertility can affect only 5-10% of people. Sexual medicine can affect 100% of the people.
Absolutely, absolutely. So I'm going to speak about male sexual dysfunction. And in fact, male sexual dysfunction is very closely linked to even female sexual dysfunction for that matter. So, Dr. Rishikesh, I have something over here, just as you had said. I took out all the literature which is available today of how COVID has affected male sexual dysfunction. So I would begin from here. It's a very important original article which has just come out on the 16th of March 2021. And the article is mask up to keep it up. That COVID-19 has increased the risk of ED to nearly 6 times. And this is as per the data which has been taken in real-time settings. The data at the moment shows that if we adjust it, then about 6 times is the amount of problems which are happening because of ED, number one. And it is enhancing. The second study which has come out, there is some problem. I think. Can you hear me now? Is it clear?
Yes, sir. Now it's clear.
Okay, fine. So the other study which has come out is, which has told us very, very clearly, which came out in the 13th of July last year, that the 3 reasons because of which erectile dysfunction is taking place in COVID. Number one is the vascular effect. We know very well that it does not only affect the lungs, the heart, it also affects the penile endothelial cells. The second thing is the psychological impact. And the third is the overall health deterioration which takes place. And all these things together bring us to an area where about 6 times there is more erectile dysfunction after by Fox out the true picture of what it is there. Unfortunately, in our country, sexual dysfunction which is also being worsened by the stress of infertility. So both these things get connected together. Is a very interesting person. He is very logical, very stable, unemotional, except for when it comes to sexual judgment. In fact, Oscar Wilde said something very beautiful about men. He said, I can resist everything except temptation. And sexuality is something in men in which this is one area where their judgment goes haywire. Now, male sexuality, the basic problem with male sexuality is that men don't have many resources available where they can learn about themselves. Men really do not share too much like women. They don't bicker amongst each other. So men do not tell each other what the problem normally is. This presentation, I think, should clarify the actions and reactions which men have, which normally are vague and confusing. There's a very big neglect to sexual medicine. And you know, the interesting thing is that even if a lot of men do not have sex after a particular age, they believe it is normal, and more so for women. So if you look at the percentage of people, you would find that about 35% of men and 54% of women have sexual dysfunction. So if you look at the percentage, it is the largest problem going around with the least possible amount of, I would say, attention which is given to this problem. Therefore, this is a problem which needs to be addressed, especially today when all are at home. Believe me, I get so many phone calls nowadays of husband and wives who have sexual dysfunction fighting at home because they have all the time in the world either to have a great time or to fight. And it's important for marital bliss and even for human beings that sexual function should be all right. So sex means different for different people. Sex could mean naked men and women coupling to the people. To physicians, sex could be a problem because of which AIDS is there. To people who talk about moral things, it could be a taboo. To an anatomist, it could mean a man and a woman, male and female. But to most basic level, sex is a genetic recombination. And this genetic recombination is based on pure chemistry. So let's understand that sex is something which has led to rebellion, jealousy, romantic fantasy, recklessness, gambling, and of course, newborn babies. But why is it such a powerful and mysterious force which we as clinicians do not take care of and people don't come out with it? So because of this, let's try to understand male sexuality, and I'm going to talk about erectile dysfunction because today's program is erectile dysfunction. But there are a few questions which I've always been asked by people, which I have enumerated over here, which really are important. And the questions are interesting because the questions normally are, why do newborn babies have erections? I can never forget. This woman came rushing to the clinic with a baby who was born at our hospital. The baby had an erection, and she said there is something wrong in his mind. The boy has an erection. Why do young boys play with their organs? Whenever they play with it, most of the times they are told, please do not touch it. This is dirty. And it really makes their mind crazy. Why do adolescents sleep in prone position? Why do teenagers want their own space? Why do people fall in love and have a crush? Why do men go weak in the knees when they see a beautiful, attractive lady? And why does their entire body language, music, and behavior change? If you look at college life and you were in love with some girl, you could never say, oh my goodness, I love you. But the moment you saw it, it was music. This is what men experience. But why does it happen? Why do men have extramarital affairs? Why does life for most men become boring and tedious in middle age? Why does sexual inadequacy, especially erectile dysfunction, play havoc with the confidence and emotions? Why does every man still have sex on their mind despite their age being anything? Now let's understand the chemical cocktail which is present. So testosterone is one hormone which leads to the sexual, sensual, alluring, dark and dangerous tones responsive for the aggressive sexual drive, erection and orgasm of a man. The estrogen is the female hormone that makes the woman receptive. The progesterone is a natural sex offender. The moment it is high, the woman does not want sex. Oxytocin is the love hormone. It is the hormone which is the super glue. It's very important for bonding the relationship. Serotonin is something which makes you either sexually demure or aggressive. And vasopressin is the monogamy molecule which tempers the influence, moderates the testosterone, and forces the original design of the male into a monogamous relationship. Prolactin is the gentle hormone for nursing, but a high prolactin would lead to erectile dysfunction. Dopamine is, which is desire personified. It is something which is pleasurable. A person who is a cocaine addict gets dopamine from cocaine. A woman who falls in love suddenly, a girl who just falls in love, my goodness, it is dopamine. DHEA and DHES enhance the sex appeal, the sex drive, the orgasm. Pheromones, we all know, are transmitted through scent. And the molecule of love is phenylethylamine, which is known as PEA. So I spoke a little bit about the chemistry, but male sexuality is very complex. It's something which is coordinated by the nervous system, cardiovascular system, endocrine system, and the reproductive system. All of them are multi-system. Please understand, a man who comes with erectile dysfunction, it may be an indicator of so many other diseases which may be there. I always tell them, erectile dysfunction is nothing but a barometer to tell me you have something else as a problem going on. So what is the normal male sexual function? So first thing for us to understand is that orgasm and ejaculation are two different processes. So an orgasm is an intense peak sensation of intense pleasure, creating an altered sense of consciousness, also with physical changes. But you know, ejaculation is something different. It's a very complex process which has two phases, and these two phases are the emission which takes place along with the ejaculation. And in this, what actually happens is that the neurological pathway and the hormone together function together. So first there is the emission which takes place, followed by the expulsion. The expulsion takes place because of the pubocavernous muscles, which at about 0.8 seconds have 5 to 6 pumpings, because of which ejaculation takes place. So erectile dysfunction. The common name for this is impotence. So I can never forget that this is one problem which a man doesn't want to tell anybody, but wants it to be right as soon as possible. And it is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. A very big study, MMAS study, reported the overall prevalence of 52% erectile dysfunction in men who had not been admitted from 40 to 70 years. So that's a very large number. So what are the risk factors for erectile dysfunction? Because before we go into the pathophysiology, we should also know what are the risk factors. So the risk factors are age. As age increases, erectile dysfunction increases. Coronary artery and peripheral vascular disease, hypertension, obesity, hyperlipidemia, trauma or surgery of the pelvis, diabetes. So if we see these things, these particular 6 things, they are also the same things which are important for a cardiac disorder. So we need to understand that if a person is going to have a cardiac event, he may have erectile dysfunction before that. And if that man has erectile dysfunction, the chances is that he may have a cardiac event. Then BPH, lower urinary tract symptoms, hypogonadism, Peyronie's disease, endocrine disorders, smoking, depression, alcohol, and certain medications. And all these things, especially smoking, depression, alcohol, and drug use, also lead to cardiac functions. And that is the reason you must have seen that after COVID, a lot of people have cardiac arrest because of endothelial cell damage and clotting after they have recovered and come home. And 6-fold chances matched to age, taking out all the other factors, that there's a 6-time chance that erectile dysfunction may be there. It's a big problem. A lot of people may say that we've survived, this is great. Even if we have erectile dysfunction, come on. But the truth is, this is something which needs to be corrected too. Now, a lot of causes are associated and the types are associated with erectile dysfunction. There's psychogenic, organic causes. Now, I will enumerate these causes, but there's a long list which I would like to send to you as a PDF, which would make it much easier. In fact, I'll have your emails with me. So I'll send you some emails. Please open them, because I'll send you a link for the whole PDFs of this, because that will be the best way to send to you. But I'll carry on from here because this could be read. But what needs to be understood most importantly is that endothelial dysfunction appears to be the final common pathway for many cases of erectile dysfunction. 2/3 of men with hypertension have some kind of erectile dysfunction. 60% of men presenting with erectile dysfunction in the clinic had undiagnosed lipid abnormalities. And more than half the men with erectile dysfunction who have no cardiac symptoms have an abnormal stress test, and 40% of these have been found to have significant coronary artery disease when studied. Of the men hospitalized for the first myocardial infarction, 64% had ED with onset 3 years or more before infarction. The last line is very important. Why? Because ED was a sign that you will have a heart attack, and they never took ED seriously. So for human beings to understand that the men are gifted, they are gifted with an organ which, if it has dysfunction, it points to something which serious could happen to you, and action needs to be taken. Now, this is a very interesting side where the psychological causes could be. How would you know this is psychogenic? If it's of young age with abrupt onset associated with a specific emotional event. The man says, I met my girlfriend, and the moment I met my girlfriend, the first time I performed okay, the second time I had an erectile dysfunction, I now just cannot get it up. Erectile dysfunction, psychogenic. Certain settings with certain people. A patient of mine told me he just cannot have sex with his wife while he can have sex at other places. He said, I have an erectile dysfunction. Psychological. A lot of stress and work pressure, especially today in the COVID. Apart from even those people who have not had COVID, my goodness, the amount of erectile dysfunction they have. The family is at home, they have all the time in the world. The stress is just not helping them. And mental status such as depression, psychosis, and anxiety. Now, what happens in organic causes? You would know this person is not psychogenic when he has persistent interest. He has all the interest in the world, but the thing won't function. If it is in older men with a gradual onset, if the person has diabetes, blood pressure, if he's taking some prescription drug medication, like he would come to you and say, I go to the market and take Manforce, Viagra, or this or that, and I just take this tablet and pop it in. Earlier it used to work, now it's not working. If they smoke, if they have elevated blood pressure, and if they have peripheral vascular disease. Any man who has this would probably be having not a psychogenic. And the organic causes are divided into 3: vasculogenic, neurogenic, hormonal. And these 3 are the causes because of which it happens. I made a small PDF which I'm going to send to you. I would be receiving the emails, so I'll send you that. Please open the mail and take the PDF of all this. Now, let me talk something about the age of how it matters. Now, let's look at the age. Now, the probability normally at the age of about 50 would be about 50%. It could be mild, moderate, or severe, but let's look at it. It is there about 50% at about 50 years. Now, what is the whole pathway? Now, the pathway is the stimulation of the glans penis in the cortex, the mind, the eyes, visually, auditory, in fact, even olfactory. It leads to parasympathetic supply to the penile arterioles, parasympathetic supply to the bulbocavernosus glands. Bulbocavernosus and urethral glands lead to mucus for lubrication. Penile arterioles dilate, erection takes place, the veins get compressed, blood cannot go back, and erection is there. And when the erection goes down after ejaculation, the sympathetic supply leads to decreased supply to the penile arterioles. The relaxation goes away, the blood goes down, and the erection gets over with. Now, just look at it in this beautiful slide. You would see that over here you have these sinusoids. And these sinusoids, once they get dilated, blood fills into them. Once blood fills into them, the tunica, which is present, the veins are between the two tunica. So these veins get compressed and the blood cannot go back. Once the blood cannot go back, the erection is there, it becomes strong and persists. See, it's something like a sink. Water comes in, the dart is there, it fills up, it persists. When the dart opens, the water goes down. This is similarity of the blood inside the penis. Just look at it over here. Whenever it is in a flaccid state, there's an arterial flow inside. It increases in size. Once it increases in size, the outflow stops because the veins are compressed and erection takes place. Now, this is the chemical pattern, and this chemical pattern is important because of the relaxation of the smooth muscles of the arteries for the blood to fill. And for this, what you need is the entry of the calcium transporters. And this takes place when you have the cyclic GMP functioning. Now, the cyclic GMP is stopped from degrading by PDE5 inhibitors, sildenafil, tadalafil. All these drugs prevented degradation. And this, what happens with this? This leads to the erection because the nitric oxide level is present and is needed very well for erection. So let's understand this particular aspect. And that is the reason it is so important. The discovery of this drug has changed just everything. Now, why is the penis like the heart? So it's interesting. A lot of people may feel very sad that I'm talking of a comparison of a penis and a heart, but it is twice likely to have a heart attack if you have a penile dysfunction. And the risk is similar for smoking and family history. So it's a very big risk factor which is present. So what do? I normally give this particular paper to all the patients where they have to mark themselves. And the questions are simple. How do you rate your confidence when you get and keep an erection? 1 to 5. When you had erection with sexual stimulation, how often were your erections hard enough for entering your partner? During sexual intercourse, how often were you able to maintain your erection after you penetrated, entered your partner? During sexual intercourse, how difficult it was to maintain your erection for completion of the intercourse? And when you attempted sexual intercourse, how often was it satisfactory for you? Whenever a person has to mark it, and if it is less than 21, he has ED. And this is one questionnaire which in a minute when the patient comes to you, you come to know that, well, that's it. So I'm going to send you this as well, which you can use in your clinical practice. Now, what is the prevalence? Prevalence I had spoken to you about. The prevalence overall, and this is what I'm calling of severe ED. This is not normal or moderate ED. This is overall is about 10%, in depression 90%, diabetes about 35%, hypertension about 25%. And this is an Indian study which came out. And in the Indian study, it was found that 21.15% of males were diagnosed with one or more sexual disorder. And it was also found that the erectile dysfunction was about 15%. So since I have two more people who are brilliant people, they are really going to go ahead and give you the most brilliant lecture about the investigation and the treatment. Because of the paucity of the time, I'll only speak about a few things in this slide. When anxiety increases because of low sexual experience in the past, negative expectations, the girlfriend has said, you don't perform well. And why did you not last so long? I saw in the movie people last so long. Anxiety. a lot of protective factors which are there. I should not hurt my woman if she has pain. These anxieties inhibit the parasympathetic activity, and this leads to low erection. However, this psychological aspect of anxiety also needs to be taken care of. And when there is the inhibited parasympathetic system, it also leads to a low arousal. And the low arousal in turn leads to negative expectations. So it's a whole cycle. And this whole cycle drives the man crazy. This would be spoken to by the next speakers who are there. And I would just like to, in this slide, bring out a few things after what I have spoken. If on the chart there is no sexual ED, no further evaluation. If it is present, evaluate for other sexual dysfunctions, hypoactive sexual dysfunction. History would be explained to you, physical examination, most important, laboratory evaluation needs to be done. Now, if it persists after modification of the drugs which the patient is taking, it could go into 3 areas as per the history: psychogenic, neurogenic, vasculogenic. If these 3 areas come, the treatment of these 3 would be different. And so this would be carried on further on. Thank you very much for being here with me. I've really loved speaking over there. I hope it would have made a difference. Thank you so much.
Thank you, Dr. Sunil, for beautifully explaining the chemistry of the sexuality and love, epidemiology, risk factor, causes of erectile dysfunction, and pathophysiology of the erectile dysfunction. So now we come to the second part, and for that I invite Dr. Paras Shah to explain us about how to evaluate such type of patient of erectile dysfunction. What are the basic and advanced modules to evaluate such type of patient? So over to you, Dr. Paras Shah. Hello.
Sir, you have to unmute yourself, please. Aras sir, please unmute yourself.
Sorry, friends. On onset, let me thank Neeraj Bhai and Foxy for giving me this opportunity to express my views on this male sexuality and sexual dysfunctions. Dr. Jindal has given excellent background of the male sexual dysfunction and particularly erectile dysfunction, and make my job literally very easy. Friends, let me explain what is the sexuality and sex. And before going to the diagnosis of sexual dysfunction, why we healthcare people do not discuss about the sexuality and sex problems to our patients. Sexuality is about who we are and how we express that to the outside world. Our sexuality is with us from the birth till the death, and we never lose it. In spite of, there are so many social obstacles. Individual has obstacles in his life, like challenging of shocks, fear, anxiety. When he was diagnosed with some disease like diabetes or any kind of disease, like what Dr. Jindal said, hypertension and all other things, so he has the fear of treatment, progresses of disease, alter body image and functions. He has a changed psychosexual status because of these diseases. He may think what partner will think about his these dysfunctions or these illness, and there is a fear of death also with the individual. However, research says, in spite of having so many obstacles in his life, patients value and want opportunity to talk about and seek help from the sexual issue from his healthcare partner. However, patients suffer in silence as they assume that if sexuality and intimacy were important, health professionals would discuss with them. And unfortunately, silence about sexuality and sexual need does not benefit your patients. Then why we healthcare professionals do not touch this subject or do not speak about this, particularly gynecologists? Because see, whenever they come to the females come to the gynecologists, they are very close to gynecologists. They want to discuss about their problems, their sexual problems, their bedroom problems. They want to discuss. But why we do find it hard to bring up and talk about sexual concern? Probably because we are not taught how to deal with these problems. We are not taught much about the positive sexuality, how to do it better, the language to discuss emotion, the language to discuss the changes. And believe me, friends, the gap between the theory and practice in including sexuality in the care of patients is vast, is a huge. These gaps are at institutional level as well as personal level. Institutional levels are lack of privacy, because whenever the patients go to the hospital, there are so many doctors are surrounded, their staffs are there in the consulting room, their assistant doctors are there in the room, so he may not or she may not or he may not get enough privacy to discuss this problem. Institute equipments are there and staff attitude. They think why this lady or why this couple are talking about sexuality when they come to the gynecologist. And there are problems at healthcare professional also. Personal issues like discomfort of discussing sexuality. Many of doctors are not comfortable to discuss about sexuality. They are great about they're doing the IVF treatment. They are great about dealing with the hysterectomy, laparoscopic surgery. But when the subject of sexuality comes, they are not comfortable to discuss with their patients. Probably many of times they have the inadequate knowledge about the subjects. They have anxiety dealing with a different group of the people. Many of times they think, see, this is not my cup of my cup of job. This is someone else. This is someone else job. I have to deal with only gynec problem. I have to deal with my subject, not the sexuality. And many of times, as I said, there will be privacy problems, or maybe because there are so many patients are outside waiting, so they do not have the time to discuss about these things, to take the detailed history about these things. And unless and until you take detailed history, you will not able to justify your patients, your client about the sexual problems. Friends, for good holistic care, it is very important for healthcare professionals to help our patients addressing this area of life. So, how we can help our patients about these things? First and foremost important thing is diagnosing of male sexual disorder by history taking. If you do not take proper history, you do not take detailed history, is present history, past history, family history, sexual preference history, you may not clinch the diagnosis and you may not be able to help the patients. This was the one question they have asked by the UN Secretary General. Can someone please tell me the solution of food crisis in the rest of the world? And you will amaze how the different people had replied about these questions. When the African delegate was asked these questions, they say, what is food? When Europeans were asked, they say, what is a shortage? When American big brothers, they are asked, they say, what is the rest of the world? And Arabian says, what is options? And friends, I have added myself in these questions, please. And when these questions repeated asked to the Indian delegate with the adding of the please, Indian delegate says, what do you mean by please? What I mean to say, the clinical presentation of sexual problem is often influenced and shaped by the culture it belongs to. In short, it's a culture bound. What I mean to say, if you go with the Western literature and try to evaluate problems in our country, you may not able to diagnose properly, or you may not able to evaluate problem by history taking. So we need to be remember our culture, our thinking, and according to that, you have to take sexual history. Before going to diagnose about the sexual dysfunction, let's describe what is a sexual dysfunction. It's a disorder which presents or inhibit sexual response or interfere with the normal sexual activity. There are four cardinal events in the male as well as in the female. In the male, it's the desire, erection, intromissions, and orgasm. And the female, it's a desire, lubrication, intromissions, and orgasm. We are not going to touch today about the female part. We are going to handle only male part. So these all four cardinal events are interlinked with each other. If the person has the desire problem, why is having desire problem? We need to probe about that part, whether it's with partner or with the situations. He may not get proper erection, he may not able to satisfy his partner, or he is having the premature ejaculation. So because if repeated this thing happen, his desires will goes down. Second part is erection. That's a main focus where I am going to talk about these things, how to evaluate erectile dysfunction in the male. Third is the intromission, that's able to penetrate or not. Sometimes it's partial or sometimes it's painful. If not able to penetrate repeatedly, then again he might get erectile dysfunction and orgasm, as I told. I already told about that part. If the person having the premature ejaculation or he's not able to get satisfied himself or his partner, he may not get proper desire and may not get proper erection because of the fear of premature ejaculations. So let's come to our today's topic, erectile dysfunction. It's inability to achieve or maintain an erection of adequate quality for penetration. We always think the persons for getting the erections, you need only one naughty thoughts. Friends, believe me, it's not correct. Just think about, if this is my finger, and if I want to lift this finger, what all things I require? I need intake bones. I need intake muscles. I need intake blood supply. I need intake nerve supply. Everything is intact. Then only I am able to lift the this finger. And we think with just one naughty thoughts we can get erections. Not, friends. It's not true. We require intake vascular supply. We require intake nerve supply. We require intake endocrine systems, intake smooth muscles, and definitely right mood. If everything is good, perfect, but your mood is not good, environment is not good, and you may not get proper erection. So you need to probe all these things in your history taking. Then what are the causes for the erectile dysfunctions? As Dr. Jindal has already said about all these things, I do not want to go in detail about all this part, but for your history taking, you need to ask these all questions to diagnose erectile dysfunction. Erectile dysfunction can be because of the psychological origin or the organic origin. The psychological origins are the fatigue, depressions, anxiety. Today's world is perform, everyone have to perform, whether the child, he has to perform in the school, he has to get good score, then only everyone will appreciate his work. If he's in office, you have to perform your best, then only you will get increment, you will get promotion and everything. And same way, you have to perform good in the bad, then only your partner will appreciate. Because of this fear of performance, this is fear of anxiety, there is a psychological erectile dysfunction. That is, if relations are there is a problems in the relations. Husband and wife had the problems, had fight in the morning, and you can't expect husband will be as romantic as in the all the other days. So conflict between husband and wife, I always say you have to resolve your all conflicts before entering in your bedroom. If you enter with your conflict in the bedroom, your sexual life will be ruined. You may not get proper erections, you do not get proper mood, and you may not enjoy your sexual movement. If there is a stress at home or at work, then also can causes erectile dysfunction. Stress from the social, cultural, or religious conflict can lead to the erectile dysfunctions and worry about sexual performance. I had already said about this thing. Even I give this example to my all the patients when I feel they have the performance anxiety. I give the example of Sachin Tendulkar. I always say if Tendulkar fails in one match, he makes zero in one match. In consecutive second match also he makes zero. In third match also if he makes zero, does he mean he cannot make century in other games? Next game he can make. He's a world class batsman. He had given highest number of century. He had made highest number of century, highest numbers of runs. Still he gets failed. If he can get fails and he can make again centuries, similarity is the same way. If you have some fear or work pressure or any problems, you may not get able to perform today. But that does not mean this is the end of your sexual life. You will able to do it again after when your problems are solved, your anxiety is solved, your depression is solved. When you are not tired, you will able to do it again. So once failure, twice failure, it does not mean it's a full step to your sexual life. The main thing, how you differentiate between the psychogenic erectile dysfunction from organic erectile dysfunction? Friends, usually psychogenic erectile dysfunctions is seen, usually it's seen in the younger age. The patient's age usually are below the 40 years of age. Patients give history, it's a sudden onset. He says, doc, I 15 days back, I used to get proper erection. I'm able to do it, satisfy my partner. I'm able to do it sexual relations perfectly normal. But suddenly one night, I could not do it. The next day morning, I again tried and I could not do it. From that day onwards, I'm not getting proper erection. So this is the classical things he's saying. Okay, onset is sudden. When onset is sudden, usually it's a psychogenic in origin. He also give history. Okay, doc, I do get morning erection. I do get nocturnal erection. I'm able to achieve erection with the masturbation. But whenever I try to keep relations with my partner, with my spouse, I'm not able to get proper erection since last few days. Or sometimes patients come and do say, doc, I'm perfectly all right. I do not have any problems. Whenever I keep relations with home, I do get perfect erection. My partner is also getting satisfied. But when I keep the relations outside the marriage, extramarital relations, whenever I keep the relation at extramarital relations, I do not get proper erection. It may be the partner specific, or probably it might be having the fear. If someone will come or someone will see us, someone will get catch, what will happen? And because of this performance anxiety or this fear, he may not get proper erections. Now come to the organic erectile dysfunctions. What are the causes for organic erectile dysfunction? There are four S, big S, which can lead to the erectile dysfunctions. Friends, you need to probe all these things in your history taking. If you have to ask these all questions when you are dealing with the erectile dysfunction. So if you take these all questions, ask these all questions in our history taking, you will able to know. You have to find out his lifestyle. There are four big S we have to find out. What are these four S big S which can lead to erectile dysfunctions? First S is smoking. Any form of tobacco, whether it's a smoking cigarette, BD, or chewing tobacco, can lead to the atherosclerosis and which can lead to the erectile dysfunction. Second S is scotch. whether it's a 5 rupees alcohol or 5,000 rupees alcohol, whether it's rum, beer, whiskey, or any kind of alcohol, can lead to the erectile dysfunctions. It says कि बहुत अच्छी तरह बताया है कि alcohol provokes your desire, but same time it takes away your performance. So you need to probe about the history of alcohol, how many since how many days he's taking or how many years he's taking, what is the quantity of alcohol. You need to ask all these questions. Third as is the stress, and fourth as is the sugar. That's the diabetes. You have to find out onset of the diabetes, durations of the diabetes, whether it's a control or uncontrolled diabetes. So you have to ask these all four S about the to find out the to make out the what is the cause of erectile dysfunction. Then are certain vascular disorders and radical cancer surgeries and certain drugs can also lead to erectile dysfunction. What are the vascular disorder? When there is not enough blood flow in the penis, can lead to the erectile dysfunction. That can be atherosclerosis because of the smoking or chewing tobacco, or hardening of the vessels can lead to the constriction of the blood vessels, and that can lead to the erectile dysfunction. The penis cannot trap blood during an erection. Dr. Jindal sir had a very beautiful shown diagrammatically about that venous leakage about that part. So if there is a venous leakage can lead to the erectile dysfunction, or nerve signals from the brain or spinal cord do not reach to the penis can also lead to the erectile dysfunction, because this when signal does not reach, your person's blood vessel will not get dilated, and when vessels are not dilated, it will not give enough blood to get a proper erections. Certain radical surgeries can lead to erectile dysfunction. So you need to ask about this, particularly prostate surgery. So whenever there is a surgery for prostate cancer surgery near the pelvic area, it's affecting penis function, because it can damage these radiations, this surgical can lead to the damaging the penile artery and penile nerve. So because of this damage, there will be a there will be a lack of vasodilatation, and because of that lack of vasodilatation, there will be erectile dysfunction. So you need to probe about the any history about the any surgery or treatment regarding the cancer surgery. Surgery and radiations for the cancer in the lower abdomen and pelvic can cause erectile dysfunction. So main thing is the drugs. There are certain drugs which are very good for the body, but these drugs can cause erectile dysfunction. So you need to ask about the drug history, whether it's on antihypertensive, particularly beta blocker. Even newer beta blockers can lead to the erectile dysfunctions. Antidepressant, SSRI groups, drugs are the main culprit to give the erectile dysfunctions. Antipsychotic drug, risperidone, anti-convulsion drug like carbamazepine, antihistaminic and recreational drugs like marijuana, alcohol and tobacco. I already said it. This can lead to the erectile dysfunction. I've seen many young people having the taking the marijuana and other drugs after a year or something, constant use of these drugs. They have the erectile dysfunction, and they come with these problems. They are not able to get proper erection. You will get surprised. They are very young, 25 years, 26 years old boy. They are not able to do this thing. So you need to ask certain questions. History taking when the persons complain about the erectile dysfunction. Sexual history by International Index of Erectile Dysfunction questionnaire. You need to ask durations and control of comorbid condition. I already said about the diabetes mellitus. You have to ask about the onset of the diabetes. You have to need to ask whether it is under control or not. Current emotional state, because if persons last, if I'll give you the example of COVID. COVID is there since last 1.5 almost 2 years now. So because of this, people have closed down, they have lost their job, they have lost their business. Because of this all thing, there will be any problems, emotional state of emotional problem. They are staying together. Because of the staying together, there are so many emotional issues are there between them, and because of this emotional issue also can lead to the erectile dysfunctions. You need to probe about the erectile syndrome, whether onset is sudden or gradual, since how long these problems are there, previous problems, advice and treatment, if they have taken any problem for this erectile dysfunction, quality of erection, whether they get proper erection when they're doing masturbation or morning erection. I always say, अगर कोई आदमी को आज कल या आखिरी 3 महीने जागते हुए सोते हुए या किसी भी अवस्था में, if he gets proper erection even in last 3 months, in any situation, whether it's masturbation, morning erection, or with the sexual act, whenever he gets a proper erection even in once in the last 3 years, probably he having the psychogenic erectile dysfunction, not organic erectile dysfunction. So you need to ask what is the onset of the erections, what is whether he gets on morning or evening. You need to ask all these things. You need to probe also arousal, ejaculation, orgasm difficulty, current drug therapy, general medical, past medical history, medications, and future of diabetic neuropathy. You must find out about these things. When you completed your history taking parts, you need to do the physical examination. What all things you should look for physical examination? You should see for phimosis and paraphimosis. Phimosis can be secondary even after age of 40, 45, 50 years or 60 years age. He will get, he has 2 kids, but he is having diabetes, uncontrolled diabetes. Then uncontrolled diabetes can lead to the phimosis. So you need to see about this phimosis and paraphimosis. If phimosis is there, so he may get pain when he is having an erection or when he try to penetration, and because of this pain he might lose the erection. So you need to look out phimosis and paraphimosis. Is there any local injuries are there? Peyronie's disease is very important thing. Where Peyronie's, where what happened in Peyronie's disease? In Peyronie's disease, there's a curvature of the penis, and because of this curvature, he may not able to penetrate, or whenever he try to penetrate, it's very painful. And because this pain, he may not able to sustain erection. You need to find out about the Peyronie's disease and bulking of the penis. Also, you should look out for that things. What other things you should find out? You should look for in the physical examination. Genitourinary examination. Is there any abnormality in the size of the testes, or in the undescended testes, or inguinal hernia or something? You should find out about when genitourinary examination. You do this. Infection and inflammation of the penis, femoral pulses, blood pressure, and if patient is above the 50 years of age, you should do the rectal examination for BPH.
Sir, sorry to interrupt.
What are the investigations?
Sir, sorry to interrupt. We are running late, so can you just wind up in few minutes? Okay, as fast as possible. Yes, sir.
What are the investigations? Complete blood count, because you have to find out anemia, because anemia can lead to the fatigue, diabetes, serum testosterone, prolactin. Friends, when you do prolactin, you need to go for the full sample, because it's a pulsatile hormones. So you need to take blood at the interval of 20 minutes, lipid profile, liver function test. We all know that testosterone is manufactured by the testes and get metabolized as in the liver. So is there any pathology in liver can lead to the erectile dysfunction? Thyroid function test, and if the patient is above the 50 years of, PSA should be ruled out. These are the blood investigations. And what are the other investigations you should get it done? Color Doppler will tell you about the situation of vessels, whether it's a vascular, whether it's a problem in the dilatations or hardening of the vessels, or there's any venous leakage. Vasoactive injection, you can inject the papaverine injections. Regiscan Plus is the most sophisticated investigations. NTPR is known as a when the patient has to admit it 2 nights in the hospital. This works on like the every man's get 3 to 5 time erection during the REM sleep, and that time this machine start work like our ECG machine, ECG scan. It's give the scan how many times person get erection, what is the percent rigidity at the tip of the penis, what is the percentage at base of the penis. So, and even divorce case is very useful, because in the court this evaluation is they consider as a evidence about this thing. I do not go all these things because time does not permit. These all the other things we can do it, but these three, color Doppler, vaso active injection, and Scan Plus, are commonly used these things. Friend, make habit. Ask routinely these two questions. It's quite normal for some men to experience problem at some stage with the getting an erection. Is this problem you have experienced? If so, is it something you would like to do something about? And believe me, friends, these two questions will change your patient's life. He will be more than happy to open up with these things. You need to ask these questions. Believe me, friends, you treat the disease, you win, you lose. You treat the person, I guarantee you will win no matter what the outcome. Thank you. Thank you very much, sir.
Thank you so much, Paras sir, for making this such a difficult topic such a easy way. I think definitely our viewers get a lot of information from that. Moving to our next session, I welcome Rahul sir. Rahul sir, are you there?
Yes, yes.
Yes, sir. Sir, over to you, sir, for the active management part of erectile dysfunction.
Good evening, everyone. At the outset, I would like to thank Neeraj sir and Dr. Apuba and Foxy for giving me this opportunity. As Sunil sir said, this is an important topic, because in day-to-day practice point of view, we see a lot of unmarried males. They'll have erectile dysfunction, and they'll come to us with suicidal tendencies. So there are very few qualified andrologists or sexologists. That means if you see the patient to doctor ratio in this field, it's very high. So now, if you see an average in every state, there are only 50 to 60 doctors in every state who are willing to treat erectile dysfunction, because most of the urologists they are not interested in treating erectile dysfunction. So I would like to simplify erectile dysfunction management for most of the doctors. See, what happens is erectile dysfunction management is very simple. In at least 70% of patients, either it is hormonal or psychological, they just need confidence and basic medications. As Sunil sir said, even giving a placebo treatment will work in many patients. What they need is your time. You have to counsel them, talk to them, you have to understand their issues, put them on some medications. Your words itself will treat 50% of patients. So, getting into the topic, first thing what we have to understand is sexual dysfunction has two issues. One is erectile dysfunction and ejaculatory dysfunction. So in erectile dysfunction, we have 5 types. In ejaculatory dysfunction, we have retrograde ejaculation, premature ejaculation, anejaculation, delayed ejaculation. These are ejaculatory dysfunctions. Most of the people, even patients and doctors, they confuse between ejaculatory dysfunction and erectile dysfunction. So coming to erectile dysfunction, so as my previous speakers spoke about classification, so we know that there are different types of erectile dysfunction. The commonest is psychological, hormonal, vasculogenic, and the last one is neurogenic. But most of these cases can be treated easily. Let us see what are the possible treatment options. So the first treatment option is counseling or sex therapy. This is mainly for patients with psychogenic ED. There's so many patients who has normal physiological function, normal vascular system, normal hormones, but only because of their performance anxiety, they can't perform. They need counseling. And second treatment option is non-pharmacological. That means patients with, anyway, I'll come to this topic again. And third one is pharmacological treatment. And fourth one is non-invasive treatment. Fifth one is minimally invasive treatment. And last one is invasive treatment. So in in medications, we have PDE5 inhibitors, and we previously we had a wonderful drug called apomorphine, which we used to give for patients with psychogenic ED, which acts at the central level. But I think now it's out of the market, and we have nutraceuticals. Nutraceuticals will work in some patients where there is endothelial dysfunction or nitric oxide deficiency. And the hormonal treatment helps in patients with low hormones or hormonal imbalance. Erythral suppositories, they're not available in India. Injection therapies like trimix or piperine injections or bimix injections, this is for patients where medications are patients are not responding with medications. Vacuum erection devices, now very few patients nowadays they need this therapy. Then comes shockwave therapy and then surgical replacement. So non-pharmacological treatment options is mainly lifestyle modification, weight loss, limiting alcohol consumption, stopping of tobacco, regular exercise. These are regular lifestyle modifications which we suggest for any patient, not only with ED, any other patient needs these lifestyle modifications. So coming to PDE5 inhibitors, this is where most of the doctors and most of the patients have doubts and inhibitions and fears and prescribing these medications. Most of the patients, why they choose a alternative therapy, because they are all worried about cardiac side effects of these medications. Most of these patients, they'll come back and start using these medications, but the fear of sildenafil, or because they see a lot of stories online about the possible side effects of these medications, and this is what drives them to a alternative medication like Ayurvedic medications or homeopathy medication. And most of these patients, if you see, they try all these possible medications and then they come to us. So now PDE5 inhibitors are psychogenic ED, mild vasculogenic ED, neurogenic ED, and side effects from other medications if patient is already taking. So now, what are the PDE5 inhibitors which are available in the market? We have sildenafil. This is first generation PDE5. We know the commonest brand which is available is Viagra, and there are so many Indian companies which are producing sildenafil alternative medications. So now next medication, and my favorite medication is tadalafil. What I feel is this is the safest PDE5 inhibitor with very few side effects, and most of us we can start them on daily doses of tadalafil without any possible side effects. 1 in 100 patients will have mild side effects like back pain and myalgia with tadalafil, but severe side effects are very less with tadalafil. And udenafil is available in the market, but it's expensive. Vardenafil is there, and avanafil, I think in a couple of days they're launching avanafil in India. Let us see what these PDE5 inhibitors do, and what are the doses we have to use, and which patient needs what kind of medication, and when. So sildenafil is available in 25 milligrams, 50 milligrams, and 100 milligrams. Tadalafil is available in 2.5 milligrams, 5 milligrams, 10 milligrams, and 20 milligrams. Vardenafil is available in 10 milligrams and 20 milligrams doses, and avanafil is available in 50, 100, and 200 milligrams. This is a comparison chart. If you see the efficacy of all these PDE5 inhibitors, it's almost same: 82%, 81%, 78%, 81%. So the timing, start time to efficacy is also almost same, but it's little high for vardenafil, and shortest is for avenafil. But even now, sildenafil and tadalafil, they are available in film form, which are easily mouth dissolvable film. They have very less time to efficiency. And sildenafil works for 3 to 6 hours. Same with avenafil. Tadalafil and vardenafil, they have long efficacy time. That means that is why most of the people, they say tadalafil as a weekend drug. That means one tablet of 20 milligrams or 10 milligrams of tadalafil can work for 24 to 48 hours. So that is why this is called a weekend pill. That means if a person take this in the weekend on Friday, that it works on Saturday and Sunday. So side effects are almost common for all these medications. So these are the possible side effects. So headache, flushing, dyspepsia, myalgia, back pain, nausea, nasal congestion, and visual disturbances. So now, how to reduce side effects in patients? Always start with low dose of medication, and once patient gets used to this medication, then the side effects are little less even with higher doses. Generally, what we do is we start with 2.5 milligrams or 5 milligrams of tadalafil on a daily dosage. So once we start this medication, only possible side effects with tadalafil are myalgia and back pain. Very few patients will have headache. So if you start with 2.5 milligrams daily dosage, initial 5 days or 1 week, they may not have any major side effect. If they are not having any side effect, then we can increase the dosage of medication to 5 mg. But if 5 mg is also not working, then what we can do is we can upscale it to 10 milligrams. So the other side effects like nasal congestion, visual disturbances, nausea, these are all common with sildenafil and vardenafil. And avenafil, which is yet to come into the market, they say these side effects are little less compared to vardenafil and sildenafil. So, and the risk of cardiac arrest or cardiac accident is very less with these medications, but the fear is always there. So that is why if you start them on low dose medications, and if they get used to, generally there are no serious side effects. So generally what we do is, even for patients who had cardiac surgery and patients with multiple medications, we generally put them on low dose of tadalafil. In fact, if you know, tadalafil is approved for long-term treatment of BPH, that means prostate enlargement. So when it is approved for long-term treatment, that it's understood that it is safe for erectile dysfunction treatment. So what are the contraindications? Contraindications are organic nitrates and severe cardiac disease. But even in these patients with severe cardiac disease, what we do is, generally if a person can climb 2 floors without any problem, then he can take sildenafil or tadalafil tablets. Or at least if he can walk for 100 meters without any problem, then they can start low dose tadalafil. So overall efficacy of these PDE5 inhibitors is around 60 to 85%. In diabetic patients, the efficacy is 35 to 55% percent. In hypertensives, it is 70 to 75% efficacy. So coming to important slide, how to select a drug. There are so many 5 types of PDE5 inhibitors. What to select? So now, if in a psychological ED patient, particularly if you see an unmarried male, as Dr. Sunil sir said, unmarried male, he has given a tablet of vitamin C. So these patients, most of them, they are normal physically, and it's only their psychological fear. So, and generally what happens is, if you put them on low dose tadalafil, that is either 2.5 milligrams or 5 milligrams on a daily dosage, they get very good early morning erections. So these early morning erections, and sometimes they get spontaneous erections. So these medications without any side effect, if they are seeing constant erections or good early morning erections, this boosts their confidence. And most of this is how we prepare these patients for the marriage. We counsel them and we put them on low-dose tadalafil. They'll be happy, and if they are not responding with 5 milligrams of tadalafil, daily doses of tadalafil, so that means there is something wrong with the vascular system. That is when we do a penile Doppler. So in patients with mild arteriogenic ED, again, daily doses of tadalafil work. Generally, you can give it for 3 to 4 months without any possible long-term side effects. But problem is, in this may not work for patients with severe vascular ED. So these patients, they may not respond to low-dose PDE5 inhibitors. They need high dose of PDE5 inhibitors like sildenafil or avanafil or vardenafil. So what happens is here sometimes what we do is we put them on daily doses of tadalafil and we give on-demand tablet of sildenafil 50 mg on the day of act. So now, but these patients in your regular OPD, uh, at least 70% of the patients, they'll have very mild symptoms or they'll have psychological ED. Most of these patients, they respond with daily doses of low dose tadalafil. And if they are not responding with these medications, you can increase the dosage till 5 milligrams and ask them to take 10 milligrams on demand, or add 50 milligrams of sildenafil along with daily doses of 5 milligrams tadalafil. But even with 50 milligrams of tadalafil or 100 milligrams of 50 milligrams of sildenafil or 100 milligrams of sildenafil, if a patient is not getting an erection, then it's better to refer these patients to a urologist or andrologist, and that is when they need further treatment. So, and the last one, which is a more complicated issue, nowadays we are seeing more and more of patients with couples with non-consummation. So here, most of these patients, even though they're having good erections, either because of performance anxiety or because of previous failures, they don't respond with low-dose tadalafil because the action of these drugs is dominated by their fear. So that is why they need a little high-dose medications like sildenafil 100 milligrams. So what we do is we have to counsel them about possible side effects and tell them it is safe to take tablet once in a week or twice in a week. This should not be taken on a daily dosage. So what we do is we start with sildenafil 100 milligrams. Once they consummate, then we reduce it to 50 milligrams, or else we can shift him to daily dosage of tadalafil 5 mg. So coming to other OTC medications which are available in the market, most of these medications, they are either testosterone boosters or they contain L-arginine. L-arginine is a nitric oxide precursor. So this works in patients with either mild to moderate vascular issues. L-arginine may not work in a patient with psychological ED. So all these other drugs, they try to increase testosterone levels. So, and these are the nutraceuticals which are generally used in erectile dysfunction management. One is L-arginine, duhimine, fenugreek, ginkgo biloba, maca roots, ginseng, tribulus, ashwagandha, safed musli. Why I am talking about these things is, if you see, most of the companies, what they are preparing is they are adding these herbal medications to L-arginine, and they are preparing a sachet form of medication. But this will help either, see, if you see fenugreek is a wonderful medication which has saponins, fenugreek saponins. They act like steroids, but they are safe. They convert total testosterone. When you take fenugreek, it's not only good for diabetes, it is also good to increase free testosterone in the body. So these medications, mostly they are targeted for people with low testosterone levels. But the available literature shows their efficacy is still of doubtful value. But most of these medications, since they have L-arginine works. So, but only problem with these medications is they're all expensive. So, what you can do in your regular practice is you can, along with daily doses of tadalafil, you can add a simple L-arginine sachet, which generally use it in obstetrics treatment. So trans-urethral therapy is not available in India. Penile injections. Coming to penile injections. So penile injections, once before we had these PDE5 inhibitors, we used to give penile injections. But these injections are short-acting. Only once they take injection, they'll have erection for 30 to 40 minutes, or it depends on the dosage of the injection. And the main risk of these injections is priapism. So what you have to do is only for patients where if they are not responding to PDE5 inhibitors, or patients are not with severe vascular AD, and patients are not willing for surgical treatment, and if their sexual intercourse frequency is once in a month or once in 15 days, then you can put them on these injections. But generally, we are not supposed to give them for outstation patients, because if in case of priapism, patient has to come back to clinic within 4 to 6 hours. So this is how we give injection. Generally, we load the drug in an insulin syringe and we directly inject into the carposa cavernosa. But generally, what we can do is we can train the patient to take injection. The only thing is, in case of priapism, they have to come to clinic immediately without wasting time. So coming to another important topic, which is hormonal therapy. Most of these patients with hormonal ED, that means they have either testosterone deficiency or abnormal TE ratio. See, this abnormal TE ratio is common in alcoholics and obese patients, where their testosterone levels may be in the normal range, but their TE ratio is abnormal. So in those patients, just giving testosterone may not help. If you try to boost their testosterone, again there is aromatization. This testosterone gets converted to estrogen, and again there is abnormal TE ratio. So this is why most of the patients, if in your regular infertility practice, you must have seen male patients, where you put them on clomiphene citrate for sperm count improvement. After 1 or 2 months, they'll come back saying that their libido is on the lower side. This is the main reason. What happens is, in most of the patients where they are on clomiphene citrate, they'll have abnormal TE ratio. If you check their estrogen levels after a month, you will see abnormal increase in estrogen levels. So, and patients with testicular failure and patients with post-anabolic steroid usage, nowadays this is very common in youth. They have been wrongly misguided by these gym instructors to take steroids for muscle building, and most of these patients, they end up with erectile dysfunction or very low testosterone levels. So now, when you see a patient with low testosterone, how to treat? Straight away giving testosterone is not indicated, because testosterone injections can suppress their HPT axis, and it can suppress their natural testosterone production. And second one, it can suppress their sperm count. So now, always in all these patients with low testosterone, you have to find out the cause. There should be a cause. So that is why when you do testosterone is on the lower side. Don't start treatment without doing other hormones. So what are the other hormones we have to look at is FSH, LH, prolactin, and estrogen. And along with, anyway, we have to do thyroid. Sometimes even vitamin D deficiency is related to low testosterone levels. So if patient is having a vitamin D deficiency, first try to increase vitamin D. Most of the patients, if it is testosterone is not getting corrected, then we have to start hormonal therapy. So now, simple therapy is clomiphene citrate, 25 milligrams once daily for a month. But don't give it on the second month. You can give a gap of 1 week or 15 days after this 1 month therapy. But for you to start clomiphene citrate, FSH value should be on the lower side. It should be less than 5. And second drug is either letrozole or anastrozole. This is for patients where either obese patients or patients with abnormal testosterone T ratio. So initially start these medications, either letrozole 2.5 milligrams or anastrozole 1 milligram on alternate days. And if patient is responding and their T ratio is improving, then you can continue same doses. Or once T ratio normalizes, next time you can actually put them on a weekly dosage of letrozole or anastrozole as a maintenance dosage. And third is gonadotropins. Though these are little expensive, but this is a wonderful way of increasing testosterone. So my way of treating is HCG 5000 international units once in a week for 4 to 6 weeks. Then I do testosterone and estrogen. Based on the levels, then I will decide whether to continue the injections or not. But generally, what you can do is, once you normalize the testosterone and ask them to change their lifestyle, regular exercise, change their sleeping habits, most of the patients will maintain their testosterone levels without injections. So coming to last option, which is testosterone injection. Testosterone injection is not for young unmarried males or males who are trying to get couples who are trying to get conceived. This is only for patients who has already completed their family. Testosterone injections are available in two forms. One is 250 milligrams and 1000 milligrams. 250 milligrams injection in intramuscular once in 3 weeks, or Cernos or other brands which are available in 1000 milligrams form, which this can be given once in 3 months. But only thing is, with these testosterone injections are either it is 250 milligrams or 1000 milligrams, at least once in 6 months or once in a year, we have to look for liver function abnormalities, and we have to look for CBP. We have to regularly monitor their PSL levels. So this is also available in patch form and gel form. Oral medications are also available, but injections is easy to give because once in 3 months it's easy to maintain their testosterone levels. So vacuum, next treatment modality is vacuum constriction device. This is nowadays, we are not using it regularly, but patients with severe ED who are not responding for PDE5 inhibitors, then this is the device which works. There are two types of devices. One is a battery operated device, and one is a pump based device. So you have to put it on the penis, press the pump, then it sucks blood into the penis. That is how you get an erection. If you see here, there is a rubber band. Once he gets an erection, he has to slide it down to the base of the penis so that erection can maintain. But only thing is, we have to advise them not to keep this band more than 30 minutes. So now this is a new therapy. It's already into the since 2014 we have been hearing about this shockwave therapy. Now there are so many centers which are using shockwave therapy. This is a new modality. What happens is this, like it aims at neovascularization. So what happens is this is how shockwave angiogenesis effect. There is shear stress, then which leads to intracellular and extracellular responses, which stimulates endothelial nitric oxide synthase, and which in turn stimulates release of vasofractors and leads to neovascularization. So there are so many companies which are producing these machines. We have PiezoWave 2, we have Storage, we have ED1000. So what it does is, it's a little expensive treatment, but for patients who are planning for surgery, this is a wonderful therapy. Generally, what happens is, if a patient who is not responding for PDE5 inhibitor, who don't want to go for surgery, most of these patients, they start after this piezo-wave therapy, shockwave therapy, they start responding to PDE5 inhibitors. But it may not cure the problem totally, but this will help in patients with early arteriogenic PD patients where neovascularization helps in getting natural erection. So they can be off the medications for at least for some time. But most of these medications, these treatments, they may not work long term, because most of these companies, most of the studies says the average duration of this improvement continues for 3 to 5 years. After that, you have to redo the therapy. This is my paper. This is my international publication on this shockwave therapy. So then, generally nowadays we are not doing any surgical treatments. It's very rare. If you compare our surgical treatment before 7 years and now, most of these patients with early arteriogenic treatment, then they respond with shockwave therapy. If they are not responding, then we have PDE5 inhibitors. They can continue on demand therapy. So surgical treatment is only for people who are not responding with PDE5 inhibitors, who are not responding with any other modality of treatment, or if they have side effects with PDE5 inhibitors, then we advise them surgical treatment. Venous leak surgeries, generally we are not doing venous leak surgeries. Their success rate is less than 20 to 30%. So we stop doing venous leak surgeries. Now only surgery we do is penile implant. We have two types of implant. One is malleable and inflatable. This is a malleable implant which is designed by our great Dr. Rupin Shah. This is an Indian implant, and these are the malleable implants from AMS and Coloplast, and this is an inflatable implant where there is a reservoir. So the difference is malleable implant will have continuous erection. They just have to whenever they want, the erection stays for erection stays like that. Only thing is, whenever we don't want an erection, we have to bend the penis. But in inflatable processes, we have a pump. We place this pump in the scrotum. So whenever they press the pump, they get an erection. Whenever they don't want erection, there is a small button here. Once you press the button, the water from the cylinders goes back into the reservoir. So advantages of penile prosthesis is it's a simple surgery with low morbidity, low mortality, high success rates. Malfunction rate is only with inflatable prosthesis, not malleable. Satisfaction rate is good, and partner satisfaction is good. But only major disadvantage is post implant infections. And second one is these implants are expensive. But after this Rupin Shah's processes, then the entire cost of the penile prosthesis surgery has come down close to 1 lakh. Thank you, doctors. If you have any questions, we'll take one by one.
Thank you so much, Rahul sir, for this elaborative discussion of the management part. I'm very much sure the audience definitely get a lot of benefits from your lecture. Sir, actually we got a lot of questions because it's a live session. I think most of it was already answered. I just wanted to say one question that is the measurement of hormone binding globulin is important along with testosterone level, or mere testosterone level is good enough?
No, initially to start with, you don't need all those hormones. Generally, what we do is only prolactin, testosterone, thyroid. These three are enough to start with. So if testosterone is, if patient says in spite of low testosterone, in spite of normal testosterone, if he says his libido is on the lower side, then that is when we have to look for all these issues. Because testosterone deficiency, generally it may not cause erectile dysfunction. Mainly it is related to libido. Even with patients, generally we see patients with atrophic testes, even they will have normal sexual function. But only thing is the difference, the time duration between erections is little on the on the higher side. That means if a patient gets good erection today, probably if his testosterone levels are low, then he may not get a good spontaneous erection for another 4 or 5 days. But after that, if he's getting a good erection, that means there is no vascular issue and testosterone. But only in patients with where there is testosterone, normal testosterone levels, but still problem is persisting, there we have to look for other hormone tests.
Sir, one questions actually in my OPD also many patients are coming and they have a normal level of testosterone, but what they have an impression that sir, I have the erections in whole night only once, but my friend have 2 or 3 times. So they actually called us ki, okay sir, testosterone level is normal, but if I get some testosterone so that my testosterone will go high and I can have performance 2-3 times in a day. It is true or what we call it?
No. See, that is a myth. That is a common myth. See, generally, most of their friends generally they say we are getting continuous erections. We are able to perform 3-4 times in a day. They're all myths. If testosterone, if they are getting good early morning erection, see, generally what I say my patients is even if they are getting early morning erections twice in a week, that is normal. So only thing is we have to counsel them that what they are thinking is wrong. Even if they are getting once early morning erection, that is more than enough. We should not
sir want to say something.
Yes.
Yes, Apollo. I always say the patient when they come and compare with their friends, my friends got 3 times or he is able to do it 3 or 4 times in a night. Now I am not able to do it. I am able to do it once in a week or I am able to do it once in a night. So I always say them, okay, boss, your garden is also greener, but you ignore your own gardens because of that others' gardens looking more brighter. Or same way you can say if you have the Mercedes car, but your neighbor bought the BMW car. So if you start comparing with your BMW neighbor's BMW and you ignore your Mercedes, so because of that you will missing the joy of riding your BMW, your Mercedes. Same way, if we get erection proper even once, that does not you don't have to compare with these things. And second thing, if you add the testosterone, if your testosterone is normal, still if you add testosterone, what will happen? I'll tell you. अगर वो जो एक हॉर्स है, घोड़ा है, उसको चाबुक मारोगे तो भागेगा, और चाबुक मारोगे क्या होगा? थोड़ा और जोर से भागेगा, लेकिन एट वन टाइम वो घोड़ा फिसल जाएगा, गिर जाएगा. उसी तरह आप टेस्टोस्टेरोन नॉर्मल को ऐड ऑन करते जाओगे तो टेस्टिकुलर फेलियर हो जाएगा. So at the end of the day, you are giving more harm to the patients. Patients will demand so many things. You don't have to follow the patient's demand. You have to follow your medical knowledge, and you have to treat according to your knowledge and all, not the patient's demand.
Right.
Can I ask one question?
Yes.
So no, basically that's to both all of you have spoken very well. Huh? Means so much new knowledge I got today. So I wanted to ask that to Dr. Reddy that
Yes,
that local application you jump that slide. So is it effective and why is it not available in India?
which one, sir? Testosterone, sir?
The Muse.
Muse is expensive, sir. It's not available in India because it's not expensive. And once there are PD5 inhibitors, it's easy to see. Muse is nothing but same Caverjet, sir. Same trimix injection. So average cost of Muse is around 2,000, 2,500 rupees.
So, but this is what it's an ointment form or it is injection form?
It's sir, it's a pessary. We just have to put it inside the meatus.
Okay. But so it's not available because of the cost or there is a FDA issue or whatever?
No, because of the cost.
Okay. But no, what I thought that because it's not oral, because so the side effects of the oral, which you are saying about flushing, headache, etc., may be less. So I thought that maybe that could be, like the other thing I wanted was what is the dependency? Means, is there any dependency of all these things? Means suppose initially for a erectile dysfunction, you start giving them for marriage problems and all. Then if they continue using it, then will it be able to perform without it?
Sir, all these medications will have dependency issues. Psychological, not medicines wise, sir. It is psychological dependency issues because once they start performing with any medication, So if they try to perform without tablet, their confidence levels will be on the lower side. So that is why what we do is we start with 5 milligrams. If they are responding well, slowly we'll bring it down to 2.5 milligrams, and then we ask them to take once in a week or twice in a week. So if their performance is not affecting, then they can stop the medication. Sudden stoppage of medication will have psychological issues.
Okay, and Paras, Dr. Paras, I wanted to ask you, so like, the partner is also very important. So when someone comes to you and you treat the male, but what do you do to treat the female? Means, for example, relationship is made up of two parts. So suppose a woman is not responsive or whatever. So how do you, because in our country, the male may come, but the couple may be hesitant to come. So what are the things that you face in your practice? As far as the partner, do you counsel the partner that, okay, change your way you have sex, relation, blah, blah, all that stuff?
Sir, you cannot clap with a single hand. So whenever the problems are there, there's a couple problems. So if wife is having some problem or she is not supporting in the bedroom, you need to talk to her also. Many of times the males, what they say, my wife is a frigid. She वो आके बोलते हैं कि वो बहुत ठंडी है. Yeah, she is very religious. She is not interested in all these things. She is, says कि no, we already have the kids. Now I don't want to do all these things. You also forget about this thing and start going to the temples and all these things. But fact is something different. Many of times she is not able to say, husband is not able to satisfy, or she is not able to reach the climax. And when she is not reaching the climax, because of these repeated things happen, she loses the interest in the sex. What happened? Most of the males, they think once they get erections, they have to penetrate and they have to start doing the sex. It's not like that. You need to, men's are like matchstick. वो जल्दी जल जाते हैं और जल्दी बुझ भी जाते हैं. Females are like iron. They need to take time to get hot. They need to time to cool down also. So you need to give more time in the foreplay. But what happened? Most of the Indian husband, they hardly give in time in the foreplay and they do not give any time in the afterplay. So, उनका काम खत्म हुआ. अगर सिगरेट पीने की आदत होती है तो they go for smoking, they turn the face and sleep. They never ask their partner whether you have reached the climax, whether you have get satisfaction or not. It's not necessary husband and wife both reach the climax on the same time. But if someone is reached earlier, that's a duty of other partner to make the journey continue and make your partner to reach the climax. You can use your finger, you can do the oral sex and all other things. Whatever way it's preferable to each other, you can do that things and reach the climax. If you ask your partner whether she's reached a climax or not, satisfied or not, and she says no, and if you get irritated or get angry on her, she will never true reply next time when you ask. So always try to ask your partner and try to see that she reached the climax. If you are honest with your work, you're kind enough or show affections and love, she will always next time will ask, okay, let's make love.
I think, Paras, there is a cultural angle also in this, because we Indians are not used to this type of communication with our partner also. What do you think?
We need to change that things, na, Neeraj. If I say, Neeraj, I have respect for you, I love you, but how you will know that things? In my heart, I love you or I have respect, but how you will know? I have to show that things, na? Because we do not have the X-ray eye to be able to find out what other person thinks about you. You have to so express your love and affections. एक सिंपल एग्जांपल मैं देता हूं. सर, ऋषिकेश भाई आपका म्यूट है.
Sir, ऋषिकेश sir.
Because this is very important point. So what I personally feel that the sex part is a very closet, and lot of people, this is one of my agenda as a Foxy president, that when the patient comes to our consulting room, we have to, beside the symptom, we have to create a system wherein we can pull out all other information like sexual dysfunction, cancer screening, is there any violence against the woman? All the other parameters that are there, we need to create a system maybe not a human interface, maybe a machine interface, where when they are sitting and waiting for the doctors consulting, we can also pull out, give them information of vaccination, give them information of antenatal preventive aspects of everything. So that is because, and the one last question before I part is that, would you think that your practice, do you think that a woman like Masters and Johnson were man and a woman? So do you think a man and a woman consulting in your practice, so you, I don't know whether you do individual practice or, but a woman consultant in sex also would make the woman part of the couple more comfortable, and they may come out with their problems more? You think that a partnership practice would be a better practice in our Indian scenario, where women are very inhibited to come out?
No, sir. Uh, I'll tell you. First thing, you have to comfortable with your own sexuality. If you are not comfortable with your own sexuality, you may not able to ask questions, or whenever you ask questions to your patients, you are not comfortable. When you are not comfortable, then how patient will comfortable to answer you? So you have to make yourself comfortable. First thing, you should be thorough knowledge about that things. You should take time. I'll tell you, sir, you are IVF specialist, male gynecologist. So you are the leading gynecologist of the India. Why? Your clients are the females. They come to you. They are not hesitate
Yeah, but
to
then
come.
I'm saying, because a sexual, they're inhibited to come out. So whether there could be
Yes,
more.
that's the thing. What I want to say, when because this subject is taboo, not about the only female. Even males are not coming up. They suffer in the silence because they do. So if you had seen my presentation in last, I had put one poster. You put this poster in your waiting area. People have this kind of problem. Are you suffering from this problem? Then if you read these things, so he'll think, no, I'm going to get some solution for this problem. So when he come in your chamber, so he'll ask, doc, something, you have put that poster outside in your waiting area. I'm facing this kind of problem. How can you help me out? But you have to do some initiate things. You have to put some poster, you have to ask these things to your patients, then they'll able to come up.
Right.
sir,
So I
I'll tell
think we
you.
need to, Neeraj, what we need is some system like a iPad, which can be there in all the consultants, where there is a interactive, like maybe a page of major pointed question. Do you have a sexual dysfunction? Have you taken vaccine? Are you being bitten by your spouse? Things like that. You understand? Maybe one page only, where it communicates the entire other parallel things that can happen in a woman's life.
question to screen out the sexual dysfunction are already available. But we have to put in the practice. Only thing is that, and we also need the public awareness. We have to do so many things to make public aware about the various.
But Neeraj, what I want is a integrative. So maybe brains like you and Sunil and all, Reddy and Paras and Apurva, what you need is an integrated one page. When she's setting all the other ancillary problems, we should be able to pick out, and this integrated interactive system should be given to all our fellow gynecologists. Right. This you create, which during my year or Shanta's year, we can then, what I want is we need to penetrate into the consulting rooms and pull out these problems from the patient so that we can treat them.
Right. And
we can have a questionnaire we can have a questionnaire in every gynec consultation room, so that before entering they can just pick it.
Yeah,
yes
but
or
it
no,
should be
yes
not
or
a
not,
long questionnaire, because people then get bored. It should be very precise. Correct. And it should be. So, when I went to US, I had tooth extraction, they ask you all those questions. So you're right. So something like a small questionnaire, which they can tick and all. And when you get in, unfortunately, the problem is we are too busy. Some of us have no patient and many of us have many patients. So there is a disparity. The doctor doesn't spend enough time with the patient. That is another problem.
Yeah.
So this kind of poster, we can put it in the waiting area, like what you suggested, taken the injections, vaccinations and all, and about sexual life. You make tick, and then they will be very happy to ask, or they will start initiate, I'm going to get some help from here.
Right, right. I agree with you. This is a very good idea.
And Apurva, there is a one question. What about the video recording link? We will send the video recording link along with the certificate to all the delegates, right?
Okay. Okay. Sir.
And there is one another question. People want to know about the previous sessions video recording. So there is either two way. If you can go to the Foxy website, it is foxy.org, where you can find all the previous session video recording link, or you can join our Facebook page, that is Sexual Medicine Committee Foxy, where you can find all the video recording link in that page, right? So there are two ways. Either you go to the foxy.org, or you can, if you are on Facebook, you can like the page Sexual Medicine Committee Foxy, where you can get all the previous recording of the previous sessions video recording. Any other question is there, Apurva?
Sir, there is no other questions because all the questions are already covered. But sir, we still I can have few minutes from our technical people. So we can have just a quickly from every our faculties, we can have an input from them. What is the bottom line message they want to give to the viewers? First, second, if there any interesting case with them which you want to discuss with them in a very short.
We start with the Dr. Rishikesh.
Yes, sir. First from the Rishikesh,
sir. What will
no, I am a student, but I have learned a lot today. Mainly, of course, I wanted to, this is
as incoming Foxy president, what would we like to do to change the scenario of
no. So my vision is only one. My vision is to integrate everything into singularity. In fact, I want, and it has to be minimal thing, because people get their attention span is very short. So we have to integrate the treatment, because I personally feel we are slowly going more towards preventive treatment, which is also important. Curative work is slowly going down. So we need to find out a new venues of treatment, and so we should be able to enrich person's life. It is just not enough to treat the person for his problem, but enrich his life as well. Means improve his life. He comes to a doctor to get a treatment for a symptom, but when he is coming to us, we must give him a lot of other inputs to enrich his already existing life. So that is which enrichment means: prevention, preventing cancer, preventing assault on the woman, improving her sexual satisfaction also, preventing her from getting battered by having too many children as well. So all these are the parts. So my vision is that if we can bring it, and we need to have, so the easiest way to pick it up is in the consulting room when they are captive. And but it has to be very short, like how Bose, you go to buy a Bose speaker, now first they make you sit in a room where you listen to the Bose experience, how the speakers are made. They give you sound, they give you a cup of tea. So that is a very crucial part when they're sitting outside your consulting, and that is where you can create how pediatricians, for example, and that can be a very good business also. You find out what are their problems other than what the problem they have come for, make them aware that there are other problems also which you can treat and enrich their life. This is what my vision is for Foxy.
Wonderful, sir.
What's your message and any interesting case you want to discuss with us, share with us?
And first of all, I think enriching somebody's life in a larger fashion is something which all of us need to inculcate within ourselves. And similarly, just carrying on from where Dr. Rishikesh had said, sexual medicine per se, because this is at the moment sexual medicine I would like to talk about, where about 40% of men and 50% of more than 55% of women have a problem which, number one, even if they do, they cannot accept. People do not accept. They can't come out with it. If they go to a gynecologist or any doctor, maybe a physician, he's not ready to listen to it. And it's very suffocating for a human being. And for somebody, anybody may feel it's something very simple, but I think it's a very deep-rooted normal problem. And I think sex is just like food, something which being or every animal everybody needs. So my feeling is, though a lot of awareness has been done in this committee by Dr. Neeraj, particularly you, and I'm sure when Dr. Rishikesh is going to be the president, it's going to be an amazing committee from the point of view of the way the vision would be. But I think some kind of a system should be there where every gynecologist is given a folder, a book, a small guide, short guide, which she could read, listen to, and then utilize every day in the clinic where she is. And it could be a written folder in Hindi, in Gujarati, in whatever language. Like I realize that most of the times, whenever I give a written paper to somebody to fill it up, the moment it comes, I don't have to ask those questions, which would take hell of a long time because they just don't want to answer it. They can't. So the moment you have it in your hand, you know what it is, and you could tell them quickly. Most of the gynecologists who have a very busy clinic don't have time. And because time is not there, I think a written formulation done by Foxy, given to everybody for mainly the 3 or 4 sexual disorders of women, 2 or 3 sexual disorders of men, which could be filled individually. Even if a patient comes for a vaginal discharge, even if a patient comes for, I would say, a breast lump, anything she comes for, if this is given and they are told initially itself that we are giving you this form, in case there is any problem which you have, you can please fill it and give it to us. And that comes as an extra consultation. And let me be honest, I mean, a consultation, the same thing, but what actually happens is you can pick up patients from there. So that is a feeling which I have.
And Dr. Sunil, what I feel is to change the whole scenario, we have to focus more on the adolescent, because we have
Yes.
to teach them what is normal sexuality. Then gradually the thing will change. That is the main issue. Because in India, what sex is the very forbidden. In the adolescent also, they are not. We don't allow them to discuss this topic. So we have
Agreed.
to change that in adolescent also.
I mean, to change the mindset of a human being of this country as far as sex is concerned, the adolescent and the young boy needs to understand what actually sex is. And unfortunately, pornography has become so common on the mobile phone that actually people think that sex is whatever is there on the pornographic site. And believe me, this is what they expect to do. And because of this reason, they get more disheartened. And in fact, दिल टूट जाता है कि दुनिया ऐसी actually होती नहीं, जबकि दुनिया तो शायद ऐसी होती है. So it has become the other way around. Instead of being sex education, it has actually created a whole story out of the mind of people the other way. So therefore, adolescent education for sex is very important. Correct.
Secondly, sir, what I feel, because in a small cities like my and majority of the cities don't have any sexologist. Okay, so what happened? We, the gynecologists, are the first one who people are actually consult for the sexual problem. And unfortunately, what happened in our primary medical education or anywhere, they are not been taught about the sexology. So we gynecologists, even we have a very roaring practice, we are very knowledgeable, we have a very little knowledge about the sexual education, sexual medicine. So as a gynecologist, I think we should have a basic knowledge of the sexual medicine so that we can give a right treatment, at least right advice to the people who are suffering from different sexual problems.
Find out the problem, and then we can direct them at least.
Correct.
You know, what I feel is that we need to, because all of you are busy now, we will talk and then we'll go to the same scenario. What we need is, if you look at, that to give you an example, in that Fortune 50, top 50, there's that Aparna Hegde is there, who is been considered as one of the top people in the world. She's a gynecologist just now. So she has created basically a program which goes by mobile phone, and they train and all. So what I'm saying is that we need to create a module which is a mobile based module which can go to thousands of people. As soon as they pick up their phone, the recording comes and they can, the recording can ask them the various questions, and if there is a problem, they can direct it. This we'll have to evolve. It's presently my mind is a diffuse. So we have to go to the people and pull out their problems. And of course, now with the COVID, see the problem, unfortunately, what the COVID has done is that we were getting into the next era of enriching lives with medicine. Now suddenly COVID has put us back. So a lot of our energies will be gone in rebuilding our lives, rebuilding patients' life. Patients are going to, next 5 years are going to go in rebuilding their wealth, their career. See, we had come to a level where we were going to the next level where medicine was being used to enrich life. Now suddenly we are in a situation where medicine is being used for survival. So the whole energy, like even I don't know, a lot of the Foxy energy will go in helping people, helping poor people. It's a lot of 5 years setback to all of us. Literally, I feel in our medicine.
Correct.
Dr. Paras, what's your say about message and any?
I agree with you, Dr. Neeraj. We should focus on adolescent sex education. Why we have to focus on adolescent sex education? Because our one-third population falls in this category, this age group, and they are the future generation. So if these generations are our base is strong, so future generation will be their future parents and all, so they can able to educate. Our is not developed country, our is a developing country, so we have the very we don't have that much fund to create awareness and all other things. So we have to focus on the generation which going to enrich and coming generations also. So we have to focus on adolescent sexuality or adolescent age group. There are lots of things, because the things are happening in their body because of hormones started developing. So secondary sex characters and everything start developing in their body. So they have so much curiosity to what is happening in their body, and because of that, many of times they when go to the parents are not comfortable with their subject, so they scold them, and children will go away. So their second choice will be the teacher. I already said that when people are not comfortable with their own sexuality, they will not able to tell. The teacher is not comfortable. Even we are seen in the 12th standard, 11th standards, when the reproductive subjects come, they say you go and read at your home. We will not going to teach you. So because they are not comfortable, so they are not teaching us. So when they don't get answer from parents, they don't get answer from teachers, what is the third choice they have? They have their own colleagues or friends. The friends' knowledge are equally what they have the knowledge. So as Dr. Sunil said, they will go to the pornography. And pornography and tickling, these all magazines and all other things, they will not give educate, but they give the tickling sensation. And because of these things, many of time series become the वो कहते हैं ना सेक्स की प्रयोगशाला बन जाती है. They have the teenage pregnancy, they have sex, child abuse, and all other things will happen. So you have to focus on the adolescent sexuality. So we'll focus
Paras,
that thing.
what I wanted, Paras, is there a website where an adolescent can go and click and listen and have, let's say, a 2 hours continuous session, which he can see whenever he has a time to learn adolescent sexuality? Because you may go to a school and you may talk. I used to do it when I was, I was very much, I used to go and give talks on sex education and all. But that is not enough. We need to mechanize it. So, we have to inform all the adolescents ki, Baba, ye site pe aap jao, ye free of charge hai, you register, you go there and listen and learn in 2 hours. All of you can record yourself into a 2-hour capsule, starting from A to Z about sexuality, and train them. And we publicize that this is the link. See, the whole problem is not the content. The whole problem is how to communicate to the mass that there is a content. How do, people would like, so this is what my vision is. Foxy should communicate, advocate, and it should provide the content which should be totally in mechanical format, in the form of website where people access it and learn.
Sir,
So there is no
suggestion-
human element. There is no human element. Now, of course, in treatment, there is human element, but for mass learning, if we bring human element, it will never work.
Sir, what happened? Sex is still taboo in our country. So whenever you put sex education or something, there are so many people, they are going to oppose these things. So what Gujarat government have done, they have changed the name. instead of sex education, they have started writing HIV and AIDS educations. So no one's opposed that things, and many schools, they are, even government schools, they are implementing these things on the name. It's the same thing, sex education. HIV and AIDS education is nothing different from the sex educations. This is the same thing, and they have published the book also on this thing, and they are giving education on this thing on the name of HIV and AIDS. So we have to change the name. We should not, where people get chance or oppose these things, we can put the other name also.
But I really
We can
think,
call it lifestyle education.
Yes, sir.
See, basically, my contention is what governments are pro population control policy, they are pro sex education policy, but they don't want to take the responsibility. This responsibility has to be taken by professional organizations, by the FOXY, because no one can touch us. We are doctors, so then, and we have nothing to lose, no election to fight. So our job is to promote all these things, because we as a collective force of medical doctors, no agency can criticize us that sex education is that. But if the government implements it, they can get criticized, then they can get worried about losing the election. So we should take that. So all these problem areas which you are saying, I totally agree. Maybe we must Neeraj, इसको change करके, नाम change करके, ज़्यादा HIV becomes too extreme. So let's have some lifestyle education, name can be changed, and you make this 2-hour module for all the kids after the 8th standard. You make a module
intimacy,
and promote that module.
Intimacy and lifestyle modification.
Whatever we can have a brainstorming of all the sexologists, all the doctors, what we should call it, and then promote it collectively.
And I think it's a brilliant idea to make a website, have contribution from everybody, have it formatted, have the website on, the link is there, different modules, whatever you want to listen to, you can listen to. Whenever you want to listen to, you can listen to. I think it's a brilliant idea. Wow. Wow.
In different languages, sir.
In different languages, yes.
You don't, Google is there, you can do automatic conversion.
But
sir, as Neeraj sir already told, that we have touched almost a lot of topics regarding with the sexual medicine. People can directly access to our Facebook page. They get, and we have the sites, we have emails. Even I and Neeraj sir, we handle this email, and we regularly getting the questions from the general public regarding those questions, and I and Neeraj sir personally reply them. So FOXY sites of Sexual Medicine Committee, this is a good, I think, good platform. So they can use that.
Apurva bhai, we should make some FAQ questions, and most of the questions are 70% of the questions are the same questions for everyone. First thing is masturbation, whether masturbation is good or bad. If I done excessive masturbation, this can lead to the weakness or erectile dysfunction. So you have to answer all these FAQ questions, common questions over there. Like Dr. Prakash Kothari says, common questions, common sexual problems and solutions. You should make something like FAQ on this base, and
but not a text FAQ. If Paras Shah talks about that FAQ, if say masturbation theek hai ki nahi, and then Dr. Paras's video comes and he tells ki nahi, masturbation normal hai, that will be more impact. So you create video FAQs.
Yeah. Yes. And so second thing, I always say example carry more weight. So you have to give example. If I tell my patients that you are normal, it doesn't, आपका जो problem masturbation की वजह से नहीं है, so उस टाइम तो वो समझ जाएगा. वापिस 2-4 दिन के बाद आएगा, डॉक आपने बोला था वो बात सही, लेकिन still I am having this problem, और ये मैं समझता हूँ masturbation की वजह से ही है. तो you have to carry the example why masturbation is normal, why it's not excessive or something like that. So you have to put some examples in that things. All the whatever things you say, if you put example, you will have the more impact.
Good. It's been an enriching experience. Dr. Rahul, you have not been saying anything.
We want to think about
actually, I thought we can have a separate YouTube channel. Sir, there are so many doctors who have their own YouTube channels, but no organization has a YouTube channel in India. So from the FOXY side, we can make a YouTube channel but all these videos should be edited, because false information should not go to the public, because these videos are seen by people from different age groups. We have to give a edited video to them, so it's like simple 2 minutes videos.
Right, very good point. So Neeraj, if you know, you need to create a like a TOG. हम लोग कैसे करते थे ना, TOG committee. You need to create, so every FAQ you must have the text which a lot of brains should sit in and create the standardized text. What is saying, so that there is no wrong communication. Then when the text is created, all of you can talk that text. You know, because human element is very important. Like if Paras talks or Rahul talks or you talk or Sunil talk or Apurva talk, that, but the text should be standardized.
Right.
The what you talk, we should be very particular as to what communication we give, because Foxy will be giving it. So
Yes.
anything wrong we say can be, you know, and this is such a sensitive issue. So we have to tackle it very clinically. तो ये शांता कुमारी के बरस में करते जब से मेरा एक फिलोसॉफी तो बहुत ही क्लियर है. I want to not do anything new in my year. I want to just consolidate. I don't need to say कि I have done this in my life. I'm the maximum. ये इंडिया का बड़ा प्रॉब्लम है. You know, why can't we just, whatever is existing, why can't we just refine it? Why can't we just make it standardized? Why can't we make it accessible to everyone? No, we don't. Suppose I start making something new. No, that's not correct. What you already have, consolidating it, improving on it, and giving access to it to everyone. That is what is important. Anna. And if you succeed, we all succeed with you. So it's very important to look at everyone in a very inclusive fashion. So let us do it. Let us, now you take this, all of you are there. See that you start working on this. We will implement it in Shanta's year. And we will make it and consolidate it in my year. And we will sustain it in the few years to come. That is important. Whatever idea you start, it should have the longevity to sustain. And for that, effort that needs to be put. A lot of people need to put, and continuity has to be there. See, one of the important things we must learn is to never look back. You should never look back. You should always look forward and go ahead. So others who are younger to you, all these are younger people, will follow us, and they will carry the flag forward. They're a philosophy of life.
So now, Apurva, we are running out of time, and we finish with the vote of thanks.
Yes, sir. Definitely, sir. So thank you so much to everyone. Thank you so much, today's chief guest, Rishikesh sir, for coming us, not only coming and giving blessing, but listening to our whole program and giving his all the valuable inputs and as well as support us. He always there to support us. Thank you so much, sir, for coming and for giving your valuable information also. And last but not the least, our faculties for today, Rahul Reddy sir, Paras sir, our own Sunil Jinder sir. Thank you so much. Thank you so much, the office bearer of Foxy, our president, Alpesh Gandhi sir, our vice president in charge, Ragini ma'am, our Secretary General Jaideep Tang sir, and definitely the main person behind all these programs, our own chairperson, Dr. Neeraj Jadhav sir. I'm really thankful to the ICOG chairperson Mandakini ma'am and the Secretary Parag Biniwale sir for credit us with the 1 credit point, ICOG credit point. Thank you so much to all our viewers for giving their full support and for their patience listening. And definitely last but not the least, our technical support team. Thank you so much. Lai always there. Rohit is always there. Thank you so much, the entire family, for organizing and for giving up the platform. Thank you so much to all of you. Thank you.
Thank you so much. Thank you very much.
Thank you.
Bye, sir.